Hi, my name is Whitney Lowe and I'd like to welcome you to my orthopedic massage, back, neck, and pelvis program. Given the unique biomechanical demands in the neck, back, and pelvis, pain is common in these regions. Poor posture, muscle exhaustion, and stress can cause pathological conditions, as can injury, such as impact trauma or overuse. Acute or chronic pain or injuries can occur in these regions and may involve muscles, tendons, ligaments, intervertebral discs, vertebrae, or other tissues. You'll find this system of orthopedic massage to be a highly effective approach to treating common soft tissue complaints. These first two tests, the Addison maneuver and Allen test, primarily evaluate for entrapment of neurovascular structures between the anterior and middle scaling muscles, which can be one variation of thoracic outlet syndrome. The thoracic outlet is an anatomical term that is broadly used to describe the region of the upper chest and lower neck region. There are three primary locations in the thoracic outlet region where neurovascular structures can become entrapped. The first site of entrapment is where the brachial plexus and subclavian artery pass between the anterior and middle scaling muscles. The next common entrapment location is between the clavicle and the first rib. The third primary location of entrapment is under the pectoralis minor muscle against the upper rib cage. The Addison maneuver is not considered highly accurate, but does provide additional information. Both the Addison maneuver and Allen test evaluate for vascular blockage in the thoracic outlet region. Because vascular structures run alongside the nerves, these tests can indicate a potential neurological impingement. Neurological symptoms, in addition, would confirm nerve involvement. Begin with your client in either a seated or standing position. Locate the client's radial pulse with your fingertips and bring the arm back into a position of extension and lateral rotation. Instruct the client to look over their shoulder towards you and take in a deep breath and hold it for several moments. While they hold the breath, notice if there is any decrease in intensity of the radial pulse. Note this should be a decrease in intensity, not in rate. If there is any indication of decrease in pulse intensity, there may be neurovascular compression occurring between the anterior and middle scaling muscles. The Allen test also evaluates neurovascular compression of the brachial plexus between the scaling muscles by monitoring the radial pulse. Again, begin with the client in either a seated or standing position. Locate the radial pulse with the fingertips and bring the client's arm into a position of shoulder abduction and external rotation with the elbow flexed to about 90 degrees. Instruct your client to look over the opposite shoulder and once again notice for any diminishing in the intensity, not the rate, of the radial pulse. Any diminishing of intensity would indicate the likelihood of neurovascular compression between the anterior and middle scaling muscles. The next two tests, the military brace and right abduction tests, evaluate neurological symptoms in the brachial plexus region. The military brace test identifies entrapment of neurological structures between the clavicle and the first rib, which is a variation of thoracic outlet syndrome called costoclavicular syndrome. Retracting the scapula decreases the space between the clavicle and the first rib, increasing compression on the brachial plexus. Have the client bring their arms into a position to fully retract the scapula as if squeezing them together in the back. Hold that position for about 20 to 30 seconds to see if it reproduces neurological sensations down the upper extremity. If neurological sensations are reproduced down the upper extremity, there's a good chance of compression of the brachial plexus between the clavicle and the first rib. The right abduction test evaluates for compression of the brachial plexus under the pectoralis minor muscle, which is another variation of thoracic outlet syndrome called pectoralis minor syndrome. Have the client bring the arm into a position of full abduction and hold that position for about a minute. If neurological symptoms are reproduced down the upper extremity, especially in the distribution of the ulnar nerve, after about 20 or 30 seconds, there's a good chance of compression of the brachial plexus underneath the pectoralis minor muscle. The next three special tests, the Sperling, distraction, and slump tests, elicit information about nerve root pathology in the cervical region. The Sperling test, also called the cervical compression test, evaluates nerve root compression by increasing pressure on the nerve roots. Compression may be from bone spurs, herniated discs, or other obstructions. There is very little space around the nerve roots in the intervertebral foramen, which makes them susceptible to obstruction. The transverse processes prevent direct contact with the nerve root when treating posterior cervical muscles, but caution is always advised with potential nerve pathology. Begin with the client in a seated position. Place your hands on the client's head and gently apply a moderate amount of pressure straight down on the client's head. If any neurological symptoms are reproduced in the cervical region or down the upper extremity, there's a good chance of nerve root involvement. The Sperling test can actually be performed in several different stages, with each stage providing more potential compression on the nerve roots. The positions for each stage include compression with the head in a neutral position first, second, the head in partial extension and rotation to the affected side. Again, pressure is applied straight down. And third, with the head in lateral flexion to the affected side. And again, pressure is applied straight down. The Sperling test is valuable because it can give you information about the severity of the condition. If symptoms are felt during the first stage, the condition may be more severe. If symptoms are not felt until the second or third stage, the condition may not be as severe. The cervical distraction test uses opposite actions from those of the Sperling test. Distraction, or pulling two structures apart, reduces pressure on the nerve roots because it slightly increases the space between the vertebrae and thus relieves compression on the nerve roots. Begin with one hand on the client's occiput and the other on the forehead. Apply a gentle upward lifting force to the client's head to apply distraction to the cervical region. If the client reports a reduction or alleviation of symptoms in the cervical area or down the upper extremity, there is a good chance of nerve root involvement. Note that some other conditions, such as cervical facet syndrome, however, may also have symptoms relieved when you perform this test. In many instances in the distraction test, when the distraction force is relieved, the symptoms will also return. The slump test evaluates problems with nerve compression or adverse neural tension in the cervical region. Several steps are performed, with each step producing additional tensile stress on the nerves. If symptoms are reproduced, cervical nerve pathology should be suspected. After each step, ask your client about changes in sensation or any increase in symptoms. The client will begin with arms held behind the back. The first step is a slump in the upper thoracic region. Next is the head, and then extension of the knee, and lastly, dorsiflexion of the foot. Each step brings increasing tension to the neurological system. If symptoms are felt during any of these steps, it's not necessary to progress to the additional steps. But any increase in neurological sensations in the cervical region or down the upper extremity could indicate neural pathology or nerve tension problems in the cervical region. Some treatment techniques require the head to be held in extension or rotation, or some combination of those movements. In certain individuals, these positions can compress the vertebral arteries, producing vascular insufficiency. The vertebral artery test evaluates the client for the likelihood of vertebral artery compression in the suboccipital region. Have the client turn their head into a position of extension and rotation, and as if looking up over their shoulder, and hold this position for about 45 seconds or a minute. You may want to have the client positioned also so that you can hold them in case the client begins to feel dizzy. If they report any sensation of dizziness, vertigo, disorientation, or nystagmus, which is a rapid twitching of the eyes, there is a good chance of vertebral artery compression in the suboccipital region. If it is going to occur, it will usually happen within the first 20 or 30 seconds. Here's a reminder of a few of the major muscles in the neck. Beginning with the deepest and moving superficially, muscles in the posterior and lateral cervical region include the multifidus, semispinalis cervicis, spinalis capitis, semispinalis capitis, splenius capitis, upper trapezius, and levator scapula. Muscles in the anterior cervical region include the scalenes and sternocleidomastoid. It may be important to treat the back, torso, and upper extremities also when addressing neck complaints. Positional release is most effective for conditions involving acute muscle injury with pain and spasm, such as in a recent whiplash injury. Begin with your hands under the client's head, positioned in a way so that one hand can move the client's head into numerous different positions. With the other hand, use a thumb or fingertips or other small contact surface to locate tender points in the client's cervical muscles. You may want to have the client give you feedback about the level of tenderness in these particular tender points, using a scale from 1 to 10. Many people use a scale like this with 1 being the least discomfort and 10 being the greatest. Once you've established that scale and located tender points, ask the client to give you a number where that pain rates. It's usually about a 7 or an 8 on the scale for a good place to start. Once you've located the tender point, move the client's head and neck into several different positions, and after each position, ask them to rate the pain once again. You want to find the position that decreases the pain the most. In most cases, after you try several different positions, you'll find ones that decrease the pain most being ones where the affected muscles are in a shortened position. Once you find that location, hold pressure on the point for about 20 seconds or so. And once again, ask the client about the level of pain or discomfort that's felt after that time period. Once you've completed that pressure for that period of time, slowly let go of the tender point and very slowly bring the client's head back into a neutral position. It's important to bring it back to the neutral and starting position slowly so that the muscles have a chance to adapt to the new tension levels. Contract, relax, stretch, or CRS, is a valuable technique for any condition that involves excessive muscular tightness, such as whiplash, postural distortion, chronic muscular tension, or other muscle injuries. These techniques use the post-isometric relaxation to enhance stretching immediately after a contraction. This first technique applies contract, relax, stretch to the posterior cervical muscles, the cervical extensors. Place one hand behind the client's head and the other on the client's shoulder to stabilize the distal end of the muscle attachments. Have the client push her head into your hands and hold that for about 3 to 5 seconds, and then relax. As the client relaxes, go up into a full stretch of forward flexion to stretch the posterior cervical muscles. This technique can be repeated several times for maximum effectiveness. This next procedure is also a contract-relax-stretch technique applied to the ipsilateral rotators of the neck, which are the muscles that rotate the head to the same side. Keep in mind that when the head rotates, there is a coordinated action of ipsilateral rotators on one side with the contralateral rotators of the opposite side. As a result, the following technique is actually working both the ipsilateral and contralateral rotators simultaneously. In this example, I'll use the muscles on the left side of the neck. Place one hand underneath the client's head so that you can hold and move the client's head in rotation. The other hand is placed against the client's forehead on this same side. I'll instruct her to hold this position. Barb, hold that there. And now relax. As she relaxes, we slowly turn into full rotation to the opposite side, which stretches the ipsilateral rotators on this side. Slowly come back to the neutral position, and you can repeat that same technique several times. Let's look again at a variation of this technique close up. Again, the client presses the head against your hand, then relaxes, and the head is stretched a bit more. Rather than returning to neutral, the process is repeated. This can be repeated several times until a full stretch is reached. The lateral flexors may also benefit from a contract-relax-stretch technique. Begin with one hand under the client's head in a position where you can move the client's head into full lateral flexion. The other hand is placed on the client's shoulder to stabilize the shoulder for the other end of the attachments of the lateral flexor muscles. Instruct your client to simply hold that position, hold, and relax. As she relaxes, bring it into a full stretch of the lateral flexor muscles and slowly return to the neutral position. Let's look at a variation of this technique close up. Again, the client presses the head against your hand, engaging the lateral flexors, and then relaxes. After the relaxation, the head is laterally flexed for more of a stretch. Rather than returning to neutral, the process is repeated from the stretch position. This can be performed several times until a full stretch is reached in the lateral flexor muscles. In some cases, there may be too much spasm or pain in a muscle to use direct pressure or certain stretching methods. These cases are a good candidate for a variation of active-assisted stretching that applies the concept of reciprocal inhibition. In this technique, the anterior neck flexors are engaged in a contraction. The posterior neck extensors are neurologically inhibited as a result. With the extensors inhibited, it is easier to gain results from stretching. Begin with one hand under the client's head and the other on the client's forehead. Instruct them to lift up against the hand that's resting on their forehead. Go ahead and lift and hold. And now relax. As she relaxes, we go fully into the forward flexion stretch. It is the cervical flexor muscles that are contracted and reciprocally inhibiting the cervical extensor muscles in this particular technique. Contract-relax stretch with reciprocal inhibition for the ipsilateral rotators works much like the previous technique. Place one hand under the client's head in a position where you can turn the head to each side. Place one hand on the client's forehead and instruct them to hold this position, hold, and then relax and turn into rotation to the opposite side. In this instance, stretching the right side ipsilateral rotators with reciprocal inhibition by engaging those on the left. This is a conservative variation that can be used if the client has more limited range of motion. The client contracts the ipsilateral rotators on the right side to engage reciprocal inhibition of the left. The client then relaxes and you rotate the head to the right. Rather than returning to neutral, the process is repeated from the stretch position. This can be performed several times until a full stretch is reached with these target muscles. Whiplash and other sudden neck injuries often cause acute spasm in the lateral flexors of the neck. The following technique is another reciprocal inhibition stretch that can be very helpful in these kinds of injuries. Place one hand under the client's head so you can both provide resistance and move the head. The other stabilizes the client's shoulder. The client holds that position as you press their head toward their shoulder. The client relaxes and you stretch in a lateral flexion in the opposite direction. Incrementally repeat the stretching method several times until you have achieved the most effective increase in range of motion. You will avoid putting pressure on the deep anterior neck muscles by using the pin and stretch technique. Because the client is positioned with the head off the end of the table, you may want to confirm that your client is not susceptible to vertebrobasilar insufficiency before performing this technique. Acute or chronic injuries can cause damage or tightness in the deep anterior neck muscles such as the longus capitis and longus colli. Due to the proximity of sensitive anatomical structures such as the carotid artery, serious medical complications could arise by attempting to treat these deep muscles. Fluctuations in blood pressure or heart rate, as well as transient ischemic attacks or strokes from the dislodging of plaque could result. For this next technique, the pin and stretch on the anterior neck muscles and their fascia, you want to position your client so their head can be off the end of the table and dropped into extension. Have the client slide up towards you, and with their head in this position, it can be dropped into extension in the particular technique that we're doing. If the client feels uncomfortable with their head off the end of the table, you can also slide a bolster underneath the upper back so the head can be dropped into extension but they're still on the table. This technique can be performed with or without lotion as it can stretch the fascia in either way. Begin by bringing the client's head up into full flexion. Place the fingertips on the distal fascia from the anterior scalene muscles and the anterior neck muscles and push in an inferiorly directed position to pin those muscles. Have the client hold the head up, so just lift your head and hold there, that's good, and now relax. As the client relaxes, slowly drop their head back into extension and slight rotation, pulling away to stretch those anterior neck muscles. Slowly bring them back into a neutral position. Let's look at the pin and stretch technique from a different angle. With your fingertips pressing into the distal fascia, slowly drop the client's head back into extension. After holding that position, slowly bring them back to the neutral position, and you can repeat this several times. The lateral flexor muscles routinely hold chronic tension, so they're a great candidate for a pin and stretch technique. Place one hand under the client's head so it can easily be moved into lateral flexion. Use the other hand to apply pressure to the lateral flexor muscles after you put them in a shortened position. Bring the head into lateral flexion to the same side, apply pressure to those muscles, and slowly pull them out into an elongated position. This technique can be repeated several times with pressure being applied at several points along the lateral flexor muscles. Begin by bringing the lateral flexors into a shortened position. Apply pressure to them with your thumb and then bring the muscle into a stretched position by laterally flexing to the opposite side while maintaining pressure on the muscles. This can be repeated several times, each time beginning in the shortened position and then moving into the elongated position while maintaining the pressure. Deep stripping techniques are performed primarily in the same direction as the muscle fibers being treated and are effective at reducing chronic muscle tension and encouraging flexibility. It's important to relax superficial muscles before applying the deep specific pressure. Be sure to check in with your client about the pressure level, and remember that the most effective treatment in a deep stripping technique is performed right at the pain-pleasure threshold. This first technique will be applied to the posterior cervical muscles that run parallel to the spine. Begin with one hand under the client's head, and the other hand is going to apply pressure with a thumb, fingertip, or other small contact surface. This technique can be performed in either a superior or inferior direction. Begin at the upper end of the cervical muscles and apply slow stripping technique down the posterior cervical muscles towards the C7 vertebra. Continue in several successive strips until the entire group of posterior cervical muscles has been adequately treated. Deep stripping is useful for treating the short but crucial intrinsic spinal muscles. In the cervical region, the intrinsic spinal muscles include the semispinalis cervicis, multifidus, and the rotatories. Use caution when performing deep work close to the spine when the client has a herniated disc, nerve impingement, or spinal joint pathology. Begin with one hand under the client's head so that you can move the head out of the way and get the other hand underneath the client's neck. Use a small contact surface like a thumb or fingertip to press right up against the spinous processes so that your thumb or fingertip is in the lamina groove. Perform a slow stripping technique down the length of the cervical region in the lamina groove. And as you go down the length of the lamina groove, pause and put a little additional pressure on any tender areas that you find in muscles where there's increased restriction. This technique can also be performed in an inferior to superior direction. Repeat this several times so that you can adequately get tension reduced in those deep intrinsic spinal muscles, such as the multifidus, many of which don't routinely get treated with other treatment techniques. You'll notice with this technique that it looks very similar to the deep stripping you just performed on the posterior cervical muscles. But do note the important distinction being in this technique you are right against the spinous processes as you run the length of the spine. That's how you'll stay in the lamina groove and work on the short intrinsic spinal muscles. Here you can see on the model where the thumb position is during the stripping technique. These are the transverse processes here and the spinous processes here. The thumb stripping technique is performed in the lamina groove right against the spinous processes in the cervical region. The primary goal of deep stripping techniques is to enhance tissue elongation. Even greater results can occur when passive engagement is added to the stripping technique. Begin with one hand under the client's head so that you can adequately move it into full flexion. The other hand is positioned to do a stripping technique with either the thumb or fingertips. Begin in a neutral position with the thumb or fingertip at the superior portion of the cervical muscles and slowly bring the client's head into flexion as you lift the head up and perform this stripping technique. Repeat this several times, moving parallel so that the posterior cervical muscles are fully treated after several passes. During active engagement techniques, there is greater density to the muscle, which allows more effective penetration of the pressure, leading to greater tissue elongation. Eccentric muscle actions are used for this technique, so refresh your understanding of eccentric actions to perform these techniques effectively. Place one hand underneath the client's head and the other hand in a position where you can perform a deep stripping technique on the posterior cervical muscles with a small contact surface, such as the thumb or fingertips. Instruct the client to push their head down into your hand, which engages the posterior cervical muscles. So if you will, Barbara, press down against my hand. That's good. And now slowly let that go. As the client slowly lets that contraction go, an eccentric action is happening in the posterior cervical muscles as her head is lifted into flexion. At the same time, there is a stripping technique performed on the posterior cervical muscles. Again, hold this here and push down against my hand. And now slowly let that go. The active eccentric elongation performed while the stripping technique is applied to the posterior cervical muscles greatly enhances tissue flexibility. Active engagement with stripping can also be applied to the lateral flexors of the neck. Position your hand so that you can move the client's head adequately from side to side in lateral flexion. And instruct the client to hold this position and don't let you move it. Barbara, if you will, just hold that there, don't let me move it. And now slowly let that go. As she slowly lets go, perform a deep stripping technique on the lateral flexor muscles, moving toward their distal attachments. Let's look at this close up. Bring the lateral flexors into a shortened position. Instruct the client to hold that position as they are engaged in a contraction. Apply pressure to the muscle and have the client slowly release the contraction as you perform a stripping technique to the lateral flexors. You can repeat this several times. It's important to treat the anterior neck muscles, such as the scalenes, in postural disorders and neck injury conditions. To avoid pressing harder into the sensitive structures in this region, use active engagement to maximize effectiveness. For this technique, the client's head is going to be dropped off the end of the table, so have your client slide up so that the head can be in a position off the end of the table. If the client's uncomfortable in this position, a bolster can be used underneath the upper back region to do the same procedure. Bring the client's head into full flexion. From this position, the scalene muscles are in a slightly shortened position. Place your fingertips on the edge of the scalene muscles and have the client engage a contraction. If you will, hold your head up. The client will hold the head up, but keep your hand underneath their head so that they'll know that you're back there for protection. And now slowly let that go. As the client slowly lets the head go, there's an eccentric contraction in the scalene muscles and you're performing a short stripping technique along the length of them. We'll perform that again several times. If you will, lift your head up. That's good. My hand stays behind here just for safety's sake, and the fingertips press on the scalenes. Now slowly let that go. Good. This can be repeated several times for maximum effectiveness. Don't perform this technique if there's any concern that your client might have vertebrobasilar insufficiency. The pectoralis minor is important to treat in certain neck pathologies. The pectoralis minor can be involved in various postural distortions and variations of thoracic outlet syndrome, where nerves or vascular structures are pinned by the muscle against the upper rib cage. Because it's deep to the pectoralis major, it can be challenging to treat. This active pin and stretch technique reduces tension in the pectoralis minor without putting excessive pressure in this area and further compromising nerves that may be compressed. Have your client reach down towards the knee, and this puts the pectoralis minor in a shortened position. Take your fingertips and apply pressure directly on the pectoralis minor muscle, but make sure that your pressure does not aggravate any of the existing neurological symptoms. While maintaining pressure, instruct the client to lift their shoulder up towards the ear as if hiking the shoulder. In so doing, we pin and stretch the pectoralis minor, applying a short static compression or a short stripping technique on the muscle during the technique. Once again, if you will, reach down towards your knee. Pin the tissues of the pectoralis minor in this position, and now lift the shoulder up towards this ear and a short stripping technique on that pectoralis minor. This is a very effective way to reduce tension in the pectoralis minor muscle. Just make sure that none of your pressure aggravates any of the existing neurological symptoms. While quite small, the 4 suboccipital muscles on each side of the neck are important in treating head and neck pain. The suboccipital muscles include the rectus capitis posterior minor, rectus capitis posterior major, obliquus capitis inferior, and obliquus capitis superior. Active engagement techniques are an effective method for addressing pain and dysfunction in the suboccipital muscles, which can be difficult to treat because they are small and lie deep to a number of other cervical muscles. Be sure the posterior cervical muscles are somewhat relaxed prior to applying this technique. Begin with one hand under the client's head so that you can move the client's head into a tilting motion, just simple flexion and extension at the atlanto-occipital joint. Instruct the client to tilt their head back as if looking up high straight behind them. Hold that, and now slowly let that go. As the client slowly lets it go, perform a short stripping motion just between the first 2 vertebrae on the suboccipital muscles. Once again, hold that there, and slowly let that go. This technique should be repeated several times, engaging the contraction each time, and gradually move out along the whole length of the suboccipital muscles on each side.